Royal College of Physicians and Surgeons of Canada, and the Board of Dermatology. She earned an honors BSc in anatomy and cell biology, as well as a medical degree from the University of Saskatchewan. Dr. Odeshi completed her dermatology residency training at the University of Alberta, where she served as co-chief resident. She now practices in Saskatoon and holds an assistant professorship at the University of Saskatchewan, contributing to both the undergraduate medical curriculum and the dermatology residency program. With a special interest in skin of color, she's passionate about advancing equitable dermatological care and addressing the unique needs of underrepresented patient populations. Kindly welcome Dr. Odeshi this morning. Thank you for joining us, Tosin.
Thank you so much for having me. I really appreciate it. It's nice to be part of such a forum, such a group. And I'm hoping to bring some insight into kind of the dermatology aspect of things. If there is ever any topics anybody's interested in or the group wants to hear more about, I'd be open to sharing. But today I thought I'd talk a little bit more about three conditions that specifically target the follicular or pilosebaceous unit. So I'm going to be talking about hidradenitis suppurativa, acne chylodilus nuca, and acne vulgaris. So if there's any questions in between, feel free to interrupt or just ask them at the end. I'm pretty flexible, but we'll just get started here. So the first condition I'll be touching on is hidradenitis suppurativa, and this has been generally under-recognized for how common it is. And a really important part of this condition is being able to identify it early on to prevent some of kind of the complication and sequelae that can come with long-term disease and scarring from this condition. So this is a chronic inflammatory disease of the epicryne gland bearing skin, and usually will affect the folds, so anywhere in the armpits, groin area, glutes. Some patients will have involvement of... Is there a question? Some patients will have involvement of the pannus region, and usually this tends to be more common in females, but can affect both gender groups, and affects about 1 to 4% of the population. So if you think about that, that's kind of the same percentage of the population you would see something like psoriasis in, which is pretty common. So we still find that this is often underdiagnosed in the general population. There's a higher incidence and severity among patients of African descent, and usually will begin around puberty or adolescence, around the age of 20 to 29, sometimes even younger, but patients will present at any age, often just because of delayed diagnosis. In terms of the pathogenesis or pathophysiology of this, so this tends to be a multifactorial disease. We do know that there's a number of components that play a role, anything from genetic factors to environmental triggers. And it's usually started or triggered by occlusion or a keratin plug that occludes the pilosebaceous unit and causes dilation of that hair follicle gland. And that dilation causes buildup of keratin cells, sebum production, and gradual buildup of bacteria as well, usually Cutibacteria acnes, but various bacteria within that pilosebaceous unit. And as that hair follicle begins to dilate, it causes a lot of inflammation. So you get recruitment of a number of inflammatory mediators and markers. And that causes further dilations of that hair follicle. You get an abscess, and eventually that abscess begins to rupture. That underlying inflammation progresses to create a lot of scar tissue, and you start to get a lot of interconnected tracts between these follicular units that further create scarring and inflammation around that area. So we know that there's a number of mediators in the innate immune system that play a role in this, and it's been quite a challenge finding which one plays the most significant role. As we'll talk about later, a lot of our medication try to target some of these pathways, and we do find there's variable response from different patients. Some patients respond really well to one treatment, while others don't. And it's been challenging to be able to predict which patients might respond to which treatments. But we find that TNF alpha inhibitors, as well as interleukin 17 mediators, play quite a significant role. And they tend to recruit a lot of our inflammatory cells as well, including neutrophils and a lot of macrophages and fibroblasts. And then we do know that there is a genetic component to this. So about 40% of patients, 40% of these patients will have at least one family member who's affected. And then oftentimes when you ask patients, is there any family history? They might tell you no, just because this is not a condition family members talk about to one another. So oftentimes other members of the family are dealing with this and they don't even talk about it within each other. There's thought to be a bit of an autosomal dominant inheritance component to this as well. And this also creates quite a bit of dysbiosis within the microbiome of the epidermis. So patients will often get a lot of secondary infection associated with their lesions. In terms of clinical presentation, so as we mentioned earlier, common sites usually the axilla, under the breast, anogenital area, buttocks, the perineum, the scrotum, vulva. Panis can also be quite affected. And we'll initially start off with comedones, so pretty mild symptoms to start, and a few spread out red erythematous papules to those regions. And then over time, they'll start to progress into these painful nodules, boils, cystic lesions that gradually enlarge and start to drain, turn into abscesses. And patients will often complain of malodor, wet clothes just from the drainage of these nodules and abscesses. And then over time, the lesions start to create scar tissue and sinus tracts, which is where it becomes quite challenging to treat once you get a lot of this scarring and sinus tract formation. So this is kind of the initial stages or initial presentations. So you can see some of these close comedones pointed out by the white arrows on the picture on the left here that will often start, and then patients will notice some of these erythematous papules. And oftentimes at these initial stages, patients might think they're not cleaning enough. Physicians might tell them they're not cleaning enough. And that's usually the first explanation for their symptoms. And then over time, they start to develop some of these really painful tender nodule cysts. A lot of them will end up in the emergency room quite often, where they're incising and draining these lesions and trying to manage their pain, or sometimes patients are even incising and draining them themselves at home. And then as time progresses, they begin to develop more of these nodules in different areas. You start to see kind of these sinus tracts. So a lot of the nodules become interconnected under the skin. You can more so palpate it. They start to get a lot of scar tissue developing in these regions as well. And same thing here. So you start to see a lot of scar tissue. In our darker skinned populations, you see a lot of post-inflammatory pigment change as well. And patients will often complain of that drainage, the malodor, and the constant pain in those more sensitive. Uh, a few more pictures. So this is involvement of kind of the inframammary area. So under the breast is a pretty common spot. And then as you can imagine, once the scar tissue builds up, similar to the picture on the left, it becomes very difficult for topicals or creams to have any impact in managing the condition. So it can spread anywhere to the to the gluteal space. It can involve the inguinal folds, and especially the gluteal area can be quite painful for patients. Just sitting, moving around, daily functions can become a challenge for these patients, and that leads to a lot of the psychosocial impact of this disease, where patients start to isolate, and anxiety and depression can kind of set in as well. So for this condition, we as dermatologists like to stage it based on the Hurley staging criteria, and that kind of guides us to how severe the condition is. So usually in stage one, patients will have a few scattered erythematous papules. They may have some abscesses. Usually they're kind of single individual lesions, and there's no scarring or sinus tracts that can be identified. By stage two, they are starting to develop multiple recurrent abscesses. There is still sinus tracts starting to develop, and you can start to see some of that scar tissue set in as well. Usually, there's still a separation between the individual lesions and sinus tracts, and you can kind of still identify each individual area of involvement. But by stage 3, you have this kind of diffuse scarring, sinus tract formation abscess where it just becomes this large tissue that's inflamed and scarred. There's a number of complications that can rise from this. So especially during the later stages, patients can actually develop fistulas to the urethra, bladder, to the rectum. So early management, again, is very important. A lot of psychosocial impact for these patients. Going to work can be a challenge. Being outdoors, participating in kind of general activity with friends and families. A lot of these patients become quite self-conscious, as you can imagine. And studies have actually showed that patients with HS have an increased level of completed suicides. Patients can also develop an anemia, often anemia of chronic disease. And we as dermatologists recognize that areas of chronic scarring or chronic inflammation have a higher risk of developing squamous cell carcinoma. So these patients actually do have a higher risk of skin cancer in these regions as well. And then depending on the depth of the inflammation and scar tissue, they can develop lymphedema to the associated limb. This condition can also be associated with a number of other conditions known as the follicular occlusion syndrome or tetrad. So it can run with severe acne, so acne conglobata. It can be associated with dissecting cellulitis of the scalp, which presents similarly, but mostly involving the scalp, with these kind of painful nodulocystic lesions and a scarring type of hair loss. And then patients can also have pilonidal cysts or sinuses usually kind of at the sacral crest there that can be involved. So some things to keep an eye out or ask patients about because sometimes we can concomitantly manage these conditions as well. And then there's a lot of comorbidities that are associated with hidradenitis suppurativa. And this is where we'll often enlist the help of our other colleagues, specialists, family physicians to kind of screen for these conditions as well as manage them if they're there. So arthritis, so up to 50% of patients with HS will actually have some form of arthritis. And this is often some form of inflammatory arthritis. It's been associated with diabetes as well. So up to 30% of HS patients will have diabetes, and they have about a 3 times increased risk of developing diabetes. It's associated with metabolic syndrome, so we often ask patients to be screened. They can have insulin resistance, hyperlipidemia. Obesity is quite common among these patients. And then again, some of those psychosocial factors, so anxiety, depression is a common thing associated with HS. And then the follicular tetrad with the acne and the pilonidal cysts we talked about earlier. And then they have an increased risk of other inflammatory conditions. So inflammatory bowel disease can run with this as well. So kind of asking them about gastrointestinal symptoms and age-appropriate screening. They can have the spondyloarthropathy, squamous cell carcinoma we mentioned a bit earlier. These patients also have a higher incidence of polycystic ovarian syndrome, and that can run with both the HS and the severe acne. And then psoriasis is also at increased prevalence. And then patients also have a higher incidence of pyoderma gangrenosum, which can be sometimes quite challenging to manage in these patients. There's a range or a number of syndromes that run together with hidradenitis suppurativa. So there's Sappho syndrome, which presents with synovitis, acne, pustular psoriasis, hyperostosis, and osteitis. And then patients can have an increased risk of HS as well. There's PAPASH and PASH syndrome, which are variants of pyogenic arthritis, pyoderma gangrenosum, acne, as well as hidradenitis suppurativa running together. So as you can imagine, usually we have dermatology, some rheumatology involved in managing these patients who have these complicated syndromes. There are a number of exogenous factors that can actually exacerbate or make the condition worse, which can sometimes make lifestyle changes challenging for these patients. So obesity is a trigger and an associated factor. However, physical activity usually makes patients feel worse just because there's a lot of friction, sweating, heat. So oftentimes we'll talk to them about weight loss and they'll look at you with a blank stare asking, how am I supposed to lose weight if I can't exercise? And every time I run, there's friction, there's pain, there's drainage. Sweating can also make this worse just from the irritation from the sweat. Heat. So some patients will find summer months are really severe or worse with this condition. Smoking also aggravate this, so we often counsel patients on smoke cessation, and then shaving, so anything that causes friction to the area. And as you can imagine, with all that open skin, patients are predisposed to secondary infection. So if there are signs of fevers, chills, worsening redness, malodorous or purulent drainage, it might be worth taking a swab just to see if there's bacterial infection. So general measures we'll often counsel patients on is weight loss. So this can be challenging, especially when their disease is quite active. And we're using some of the medicated, or we're recommending chatting with their family doctors about some of the medication options for weight loss as well for these patients, because we find this can significantly improve their disease. Smoking cessation can also have a big impact. So that's another thing I send patients back to their family doctor for, just to discuss cessation strategies. And then anything that they can do to reduce friction or moisture to that area. So wearing loose, breathable garment, absorbent powders or pads to those regions. Topical aluminum chloride, which we'll often use for hyperhidrosis. So they can buy this over the counter. It's known by the brand name of Drysol, and they can use that to decrease the sweating. However, this can be irritating or burn if they have a lot of open sores to those areas. The other thing we can sometimes do to help the sweating is Botox injections into the axilla or areas that have profuse sweating. And then laser hair removal has also been shown to be quite effective for helping a lot of these patients. We use a lot of, we often use multimodal therapies for these. So we'll use a combination of our topical agents, systemic therapies, to kind of manage the severity and the frequency of flares. Topicals are a nice kind of baseline starting point, and these are nice to start in the family doctor's office or even for patients that come into the emergency room. So we'll use a lot of our antiseptic washes, so chlorhexidine wash or benzoyl peroxide washes. And what I'll often tell patients is to use this every day when they're having a flare. So apply it to the area, let it sit for about 2 to 3 minutes, and then rinse it off. And then when they're not flaring and things aren't as bad, they can use these more as maintenance treatment a couple times a week, so 2 to 3 times a week to those areas. And then we can also use our topical antibiotic agents or combination of benzoyl peroxide and clindamycin to those areas. And these help both with kind of that dysbiosis of the microbiome as well as the inflammation to those regions. We do a lot of intralesional Kenalog injections for these patients. So patients will often find things are good, and then all of a sudden they develop a single painful nodule or cyst to either an armpit or to the glute. And usually what I tell them is call in if you're having a flare, and if they have a few active nodules, we can inject them with a little bit of Kenalog, and it will usually settle down pretty quickly. So this is also something that can be done like in the family doctor's office or even the merge. Usually it's easy to send a prescription for this Kenalog to the pharmacy and the patients just bring the vial with them. And often I'll use a concentration of 5 milligram per milliliter. So I'll dilute the 10 milligram vial by half, and then do an injection straight into the nodule until it blanches. So you can actually see the nodule become white. And that often will settle down that nodule pretty quickly. And we'll often prefer that to patients trying to kind of incise it and drain it themselves at home, because that has a high risk of causing more scarring. We also use a lot of oral antibiotics for this condition. So in dermatology, we love to use the tetracyclines more as an anti-inflammatory agent. And doxycycline and minocycline are often our first go-to. Usually we put these patients on a long-term course with the antibiotics, so usually about 8 to 12 weeks. And some of our immunosuppressive systemic agents will actually require them to trial a 3-month course of the oral antibiotics before the government will even approve them for those medications. So this is usually a first step for most patients, and a lot of patients will actually find this effective. So it'll settle down those acute inflammatory lesions quite quickly, and then we'll use the oral antibiotic courses intermittently for those more severe flares. We can also use erythromycin for patients who have other or allergies or sensitivities to tetracyclines. We use a lot of Septra. And then for more recalcitrant disease, we'll consider things like rifampin and clindamycin combinations or rifampin and minocycline, or we'll even do like a triple therapy with a fluoroquinolone, metronidazole, and rifampin. And then we have a few patients that are really, really severe, and we'll consult our infectious disease colleagues at that point to discuss treatment with IV ertapenem. So these patients will actually have a PICC line put in, and they'll be on about a 6 to 8 week course with IV ertapenem. And when we can get this, it works really well to kind of settle down those really severe patients really quickly. And an oral dapsone. So this one we don't use as much because it does have a few side effects that can come with it and some monitoring blood work, but for some patients it can be an effective add-on. Uh, In terms of the pathogenesis of HS, so some patients will find that their severity or their flares are actually mediated by hormonal factors. So they'll find that about a week to their menstrual cycle, things will start to flare and become more active. For these patients, we often will try kind of anti-androgen therapies, so things like spironolactone. You can give them anywhere from a range of 25 to 200 milligrams according to the literature. Usually we keep them on a dose of about 100 milligrams daily. And then the side effects that can sometimes come with that, it can sometimes decrease blood pressure. So we are a little bit more careful in patients who have a history of low blood pressures. We try to avoid this in patients. Sorry? Uh, we try to avoid this in patients who are planning a baby in the near future, just because this can sometimes have an effect on babies as well. And then oral contraceptives, I'll also send patients back to their family doctors just to talk about this as an option, because this can also be helpful. And finasteride, dutasteride are lower down on our treatment strategies just because they are teratogenic and we don't want to use them in women of childbearing age. So this would be more a consideration in our older females who are not planning on having any children. Studies do show that there can be some benefit, especially in patients who have associated metabolic syndrome, with adding on metformin. So usually I'll start them on a dose of 500 milligrams daily, and then we'll kind of titrate up to TID. Of course, the GI side effects are kind of the rate limiting factor for the metformin. Retinoids can also be a very effective treatment strategy. So we'll use isotretinoin or Accutane or sometimes acitretin, depending on what their insurance covers, just to see if we can get those cystic nodules under control. And then for those patients that really don't respond to any of those treatments, have tried courses of oral antibiotics with minimal response, we start targeting some of our immunosuppressive agents. Our first lines are usually our TNF alpha inhibitors, which include infliximab and adalimumab, also known as Humira. And Humira is actually Health Canada or FDA approved for managing HS in patients 12 years and older. They do have a criteria they have to meet, so they have to have trialed at least 3 months of the antibiotic course. So this is something that can be started in community, like with family physicians. So if you start them on antibiotics, they have a shorter wait time before we can access some of these drugs. They also have to have a certain severity to their disease, so at least a Hurley stage 2 or 3 with multiple abscesses, nodules, and sinus tracts as well. And as you can see, this provides improvement in their lesions. So about 52% of patients will actually find that they improve or they have long-term control with adalimumab. However, we don't have complete, I guess, remission of the disease. So they notice about a 32% reduction in abscesses, nodules. So overall, it improves disease severity, which is very important. But we haven't quite found a cure or 100% effective treatment for this condition, but we want to limit the inflammation as much as possible. The other systemic agent that's approved for HS is Cosentyx or secukinumab, and this is also an immunosuppressive agent that targets interleukin 17. Similar to the adalimumab, It also provides improvement in the number of nodules. And usually about 42% of patients will notice about a 55% improvement in their disease severity around week 16. And then the improvement kind of increases the longer they're on therapy. So about 57 to 60% of patients will notice a 50% improvement in their disease at week 52. Variable response. So I found even in practice that some patients respond really well to antibiotics, while others will respond really well to oral hormonal anti-hormonal therapies, while others respond really well to immunosuppressive treatments. And then there's a few patients that we have on multimodal therapy. So we have them on antibiotics and anti-TNF. We have them on the topicals, and we're just trying to control the inflammation as much as possible. So there's a few really recalcitrant cases out there. And in those cases, we'll also start to consider some of our off-label treatments. And this is often in conjugation with our rheumatology colleagues. So anakinra is an interleukin-1 antagonist, which can have a broader range of side effects, but worth considering in some of these patients. And then some of our other interleukin-17, interleukin-12, and 23 agonists. Topical resorcinol, if we have access to it, and can be expensive to mix up, can sometimes be a topical options for these patients. And then photodynamic therapy, which also often is not covered, might be helpful for these patients as well. So these are some of the off-label things that we can do. And then surgery. So we'll actually do the smaller cases such as this in our office. So these are called de-roofing procedures. And we prefer them actually to incision and drainage, which has been a common method of managing these when they come to the emergency room. But this, we pretty much open up the sinus tract and cut out all of the scar tissue around it. And we actually won't close it up with any stitches or sutures. We'll leave it open to second intention healing. And we can often do a large surface area. So in the axilla, glutes are common areas we'll do. And patients heal really well, surprisingly, with just gentle wound care, often with a dressing and just plain Vaseline or petrolatum ointment to the areas as they heal. And the nice thing about this is because we kind of remove the scar tissue, we removed kind of the pilosebaceous unit, so the patients don't get regrowth of the hair in that area. This tends not to kind of flare up anymore. They just get that kind of benign scar to that region. So the major takeaway points for HS, I think I just wanted to highlight how the condition presents. So it can be subtle, and I've had a lot of patients come in that their symptoms have been ignored, or that they've been told to clean better or wash better. And this is not the case. This can affect anywhere from skinny patients to obese patients to all walks of life, young and old, and can have quite a severe impact on their quality of life, on their mood, as we've mentioned earlier. So early recognition and at least trial of some of the topicals is warranted, and in severe cases, definitely a referral to dermatology for further management. Any questions about hidradenitis suppurativa? Anyone seen a few cases?
Thank you, Dr. Odeshi.
Mhm.
Another takeaway here is the risk with mental health. And most people on this platform are GPs, and it's just telling us that also not just in the case, also to take the history around mental health. Thank you.
Thank you so much for that. Yeah, that's very important. And it's very important to recognize that most patients are quite self-conscious bringing this up because it's in sensitive areas. So when they do bring it up, just acknowledging it and kind of screening how it impacts or affects their quality of life is really important as well. All right, so we'll kind of power through the rest. So I also wanted to mention, talk about acne condylus nuca, which also affects the pilosebaceous unit. And this is more common in males, often in patients of African descent, but can affect any ethnicity group. And usually, again, will present around adolescence, early adulthood. And I find that in the community, I see these patients a lot. In clinic, I don't see them quite often. So I think it is often either ignored, under-recognized, underdiagnosed, but there's definitely things that we can do for this. About two-thirds of these patients will have associated seborrheic dermatitis, and then about one-third of these patients will also have folliculitis barbae, which there is a theory that these two tend to be co-associated or run or coexist. The pathogenesis in itself, we don't really understand why it happens or why some people get it. There's a few theories out there that it's aggravated or caused by kind of chronic irritation, friction, hair shaving procedures or patterns, and a chronic folliculitis. Some believe that it's the same kind of pathogenesis as pseudofolliculitis barbae, where you get this transfollicular or intrafollicular inflammation that is caused by curly hair. So you patients with really curly hair type, their hair kind of curls down into the epidermis or within the epidermis and causes this inflammatory process that triggers this whole pattern. So oftentimes, similar to HS, they'll start with a few kind of folliculitis, erythematous papules, often affects the posterior neck and occipital scalp. And then over time, they'll start to develop into these more nodulocystic lesions, plaques, painful pustules. And then once left for a long time, they can progress into kind of these hard papules, plaques that start to coalesce into this larger keloid-like lesions. And they can be quite large and painful for these patients. And they can also develop into abscesses and draining sinuses, similar to what we see in HS. If the scarring is left to progress long enough, it can develop into a scarring type of alopecia, which at that point is irreversible. So they get a more permanent hair loss in that region. There's a number of general measures that we can use or try for this. So just avoiding tight headgear or anything that really causes friction to that region, sweaters, collars, avoiding kind of razoring or edging the hairline, just to again limit the irritation and friction to that area. Recognizing when there is an associated secondary infection. So doing a swab if there is kind of purulent drainage starting to happen or oozing and worsening pain. And then a lot of these conditions, if we can catch them early or start treating them early, we can manage them with our topical retinoids, topical steroids, topical antibiotics, as well as a combination of both. So usually the topical retinoids will do well. I've used TAC2 pump, which is a combination of benzoyl peroxide as well as adapalene for a lot of these patients, and that can settle the inflammation pretty quickly. And then sometimes we'll use a topical steroid during the day and a topical retinoid at night. Once they start to develop more of those larger keloid-like lesions, they might need intralesional Kenalog or steroid injections to those areas. So if that's the case, usually I'll see them about every 6 to 8 weeks to do those injections to settle down those lesions. And then when things are really severe, we'll start again talking about oral antibiotics. So our tetracyclines, doxyminocycline, tetracycline, and then isotretinoin or Accutane can be a good option for really recalcitrant cases. And then we have a few cases or nodules where they're really large. So for example, the picture on the lower right, like this, is a pretty large keloid. We might get some improvement with our Kenalog injections, but usually at this point we discuss considering surgical excision of these lesions with the patients, and oftentimes we'll follow excision with more intralesional Kenalog injections. Sometimes in really severe cases, we'll also refer them to a radiologist for radiation therapy, which can sometimes ablate some of these lesions. So similar takeaway with this, early recognition and diagnosis is key. And there's lots of topical therapies we can do to kind of decrease the inflammatory cascade before they progress into these kind of tense, painful, keloidal-like scars. Because at that point, once they become large, inflamed, they develop scarring alopecia. It becomes more challenging to manage. All right, and then our last topic here is acne vulgaris. So this is a very common one. So if you're in a city or a place where there's limited access to dermatology, like there is in Saskatoon, patients with conditions like acne tend to be on our wait list for a long, long time, which is very unfortunate. And ideally, we want them to have been tried on some form of systemic or even oral medication just to prevent some of those sequelae with the scarring that can happen. So this becomes bread and butter for us, but unfortunately, because the wait list here is currently 2 to 3 years for some of the cases, it becomes important that there is some management started before they can see us. So this is usually again seen in our adolescent population, usually around puberty, but it's actually a high population of adults will also still have adult acne. So we find about 50% of cases will persist into adulthood, which is a large number, and tends to be more severe in our male population. Bit of a lower incidence in Asians and Africans, more common in Caucasians and indigenous population groups. And again, this still has a high psychosocial aspect to things. So our adolescent teenager with severe acne might not be participating in those activities, might be isolating, higher risk of anxiety, depression. So this is not just a skin condition, but can have significant impact on patients' overall quality of life and day-to-day function. So there are some dietary factors, some general measures or associated factors to consider. So there is a genetic component to this. So pretty multifactorial, multiple genes can kind of predispose you to develop an acne, but patients with really severe cystic acne will often have a history of a parent who also had severe acne in adolescence. There's a number of medications that can sometimes aggravate acne to be aware of. So kind of going through their medications and seeing if there's anything that could be triggering or worsening their acne. So lithium, we use a number of medications as well that can sometimes worsen or trigger acne that we're aware of. Some patients will find it's more so associated with their menstrual cycle. So with those patients, we'll sometimes target more hormonal treatment strategies. And then there's a group of endocrine conditions which tend to present with more severe recalcitrant acne. So things like polycystic ovarian syndrome is very important to keep in mind. And then other conditions that will not just present with the acne, but with other comorbidities. And then dietary things. So whey protein. So there's a lot of our teenagers who are on supplements, bodybuilding, working out. So just being aware of those proteins that can sometimes exacerbate it and counseling around that. Patients who drink a lot of milk. So this is almost a balancing act because diets that are very high in milk, especially skimmed milk, can worsen acne. And then high glycemic diets as well. So if they're drinking lots of sugars, sodas. So we still want them to drink milk, just have a balanced amount of intake of both sugars and milk. And then B12 supplementation can also sometimes has been reported to sometimes be an aggravating factor, especially if they don't have any deficiencies that are being treated. And then the pathogenesis for acne is very similar to that which we talked about in hidradenitis suppurativa. So again, you get that increased keratinization and sebum production within your pilosebaceous unit that causes dilation of the hair follicle, and then you start to develop these comedones, microabscesses, and recruitment of inflammatory cells and markers. You get proliferation of your bacteria, predominantly your Cutibacteria acnes, which then again recruits more inflammatory cells. You develop your nodulocystic lesions that rupture and then kind of further perpetuate that inflammatory cascade. So there's various stages of acne, various severities. So comedonal or non-inflammatory acne will often start with these open or closed comedones, usually about 1 to 2 millimeters, skin-colored papules. In the case of blackheads, they're more darker in pigment, just due to the oxidation of the lipid within the comedone. And these patients don't have as many inflammatory papules or nodules. Usually, you can trial them on some of the over-the-counter treatment modalities, which we'll talk about, or you could just start them on a prescription topical treatment as well. And then you get your inflammatory acne. These ones have a tendency to scar, especially if left for prolonged periods of time. So you get a lot of your erythematous papules, pustules, nodulocystic lesions. Severe cases might develop sinus tracts and can be quite painful and inflamed for these patients. Scarring and post-inflammatory hyper and hypopigmentation is a common sequelae for the acne. So early treatment will help and prevent the severity of this, but usually the post-inflammatory pigment change will fade with time. But there's a few things that we can do around counseling in terms of use of sunscreen and some pigmentary agents that we can use as well if it becomes really bothersome to the patient. And this is often after we've addressed the underlying acne. So sometimes patients want us to treat the scar while they still have acne going on. And that's kind of counterintuitive because as they're still developing inflammation, they will develop new scar. So the first line of treatment is to first address the acne. And then some things that patients need to know is that they often want us to fix their acne really quickly. But even with our topical agents, we have to give it at least 6 to 8 weeks before we start to see some benefit. Sometimes patients will spot treat with the topical retinoids. Usually I recommend doing the whole field because the goal is not just to treat the acne, but to also prevent new acne lesions from forming in newer places. So field treatment will help with both. And then there's this whole new social media movement around skincare, using having a 20-step skincare routine. And often I recommend simplicity for patients. So there's a number of irritants, toners, especially once we start to add on prescription treatments that can further irritate the skin. So often I recommend having a very bland, gentle cleanser on board and a bland, gentle moisturizer. And there's various brands out there, things like Cetaphil or CeraVe are common ones we recommend. And then looking at their makeup products, their soaps, and seeing if they are labeled as non-comedogenic, because sometimes those products also have a propensity of producing acne or causing acne. So finding products that specifically say that they're non-comedogenic is important for these patients as well. And then manipulation of the lesions. So it's very easy for patients to want to pick, scratch at the lesions, and this just perpetuates the risk of scarring. So oftentimes I recommend avoiding scarring, picking and scratching at the lesions as much as possible, because that can create another whole subtype of acne known as acne excoriae. So I thought we'd go over some of the topical agents for managing acne. So benzoyl peroxide, which we talked a little bit about in HS, can be used. So there's various concentrations out there. Usually I'll start them on the lower concentration with the cleanser. So there's this acne foaming cleanser by CeraVe, which is 4% benzoyl peroxide concentration. And you'll find there's various formulations of this over the counter as well. And then prescription versions at the higher concentration that we can try. These can be irritating and drying to the skin. That's why I usually will start at the lower concentration and gradually try titrate them up. And then besides irritation, can also bleach and stain the clothing. So usually I tell patients just to if they're using a gel, let it dry before they put on their clothing. Topical antibiotics, so clindamycin is a common one that we'll use as well. And then we will also try some of our other agents. So azelaic acid or dapsone or axone gel can be quite effective for these patients. And we use these in rosacea as well. Azelaic acid has been shown to also decrease or help with hyperpigmentation. So if you have patients that are prone or that's kind of one of their major concerns, this might be a nice one to consider adding on. And then salicylic acid, glycolic acid, and lactic acid can be found in over-the-counter preparations as well, and can be helpful for more milder cases of acne. And then topical retinoids are kind of our workhorse for managing the acne. So there's various formulations out there, anything from Differin to Araslo to Acleve that we can use. Oftentimes, what I choose will depend on the patient's insurance coverage. And then usually I'll ask them to use this topical or the retinoid at nighttime, starting with use every other night or every 2 to 3 days initially, just to decrease the risk of irritation with the topical retinoid, and then gradually working up to nightly use. And then besides irritation, other things that can happen is this can make them a little bit more sensitive to sunlight. So it's very important that they're wearing their sunscreen during the day. And then usually I start with same thing with a lower concentration of the retinoid, and we can kind of gradually work our way up in terms of strength. Things that they can do at home to decrease risk of irritation or redness with the retinoid. So usually I say if you're using it every 3 days and gradually working your way up and you're still getting irritated, adding a moisturizer on top of your retinoid, or even doing the sandwich method where you put a moisturizer below, the retinoid on top, and then another layer of moisturizer on top can make it more tolerable. And then the last agent on this list is Winlevi. So this is one of the newer ones on the market, and it specifically targets more hormonal DHT, sorry, receptors. And this is really helpful for patients who have more hormonal acne. And I also find this one nice in combination with some of the systemic therapies because this one is not drying, and patients find that even if they get dryness with the Accutane or the Purist prescriptions, this still provides a layer of hydration and still therapeutic. And then we have a number of combination creams out there that we can also prescribe. So a combination of benzoyl peroxide and our antibiotics, so clendoxil, benzaclin gel. We have combination of the antibiotics and the retinoids, usually Biacna is the common one, which is a combination of clindamycin and tretinoin. And then TAC2 pump or TAC2 pump forte, which is a combination of adapalene and benzoyl peroxide, can also be quite effective for patients. And then this is also a newer one on the market. So I just recently started using this one. I haven't seen patients back who have tried it yet, but it's a combination of clindamycin, adapalene, and benzoyl peroxide. So you're getting all three in one tube. They are getting pretty great coverage in terms of insurance coverage for this, but the main concern is sometimes it can be irritating. So again, advising around gradual use, so starting every 3 days, then every 2 days, then daily, and then moisturizer on top of this as well. And then, of course, we have a number of oral agents. Again, we love our antibiotics for their anti-inflammatory effects. So doxycycline will often use another 8 to 12-week course just to kind of settle the inflammation, and we'll might sporadically use it intermittently as needed. For those with more of a hormonal-based acne, we'll recommend oral contraceptives. So oftentimes we'll send them back to their family doctor to consider starting this or have discussions around starting this. And then spironolactone is also another one we like to use for more hormonal mediated acne. And then oral isotretinoin. So Claris, Epuris, and Absorica, which is the newer type of Accutane on the market. The selling point for the Absorica is that it's better absorbed and better tolerated than the other Accutane formulation or isotretinoin formulations. And then I just wanted to put a brief plug-in of acne fulminans. So this is a really severe form of acne that will show up or present with systemic symptoms. So these patients might present to the family doctor's office or might present to the emergency room, and they will have very severe inflammatory nodules, cystic hemorrhagic lesions that can involve the face, the trunk, chest, back, and extend to the arms as well. They will often also have fevers, chills, just feeling unwell. They might describe muscle pains and aches. Sometimes, if we actually image them, they might have osteolytic lesions that are noted on x-rays. And then they might have associated erythema nodosum or hepatosplenomegaly as well. The common trigger for this is starting a patient who has severe acne on a high dose of isotretinoin. So interestingly enough, patients who come in with severe acne and we want to treat them with Accutane, I'll often start them on a lower dose of Accutane just because of the risk of acne fulminans in these patients. And acne fulminans is different than acne conglobata, which is a severe form of acne, but these patients will not have any systemic manifestations or symptoms. So these are some pictures of acne fulminans. So as you can see, it's quite more severe than your regular acne. These patients will develop a lot of these severe, deep nodulocystic lesions. They'll develop hemorrhagic crust on top of them. Sometimes you can start to get secondary infection on top of the lesions themselves. So if you start to see some of these very severe forms of acne, it might warrant some investigations. So sometimes we'll do a CBC, inflammatory markers like CRP, ESR, which can be elevated, a urinalysis, liver enzymes, and then we might screen with an X-ray if they're describing specific skeletal pain or symptoms, just to screen for those osteolytic findings as well. As mentioned, these patients are often on Accutane or retinoid that kind of set this off. So usually we stop the retinoid and we'll start them on prednisone, often for about 2 to 4 weeks. And then we'll gradually reintroduce the Accutane or the retinoid back into the system while overlapping it with the prednisone. So they're on a longer course of systemic immunosuppressive therapy, usually about a month to usually about 2 months to 3 months, I would say. And then over time, we'll gradually taper them off the prednisone as their acne improves. Sometimes in really severe cases, we have to bring in some of our other immunosuppressive agents, things like TNF, interleukin 1. And these are patients who usually have a lot of associated systemic manifestations or have syndromic symptoms associated with this as well. So that is it for acne. And for my presentation overall, I'm wondering if anybody has any questions, comments.
Um, there's a question here that from Dr. Lotfi. Cases that present with hypertrophic keloid. How do we manage?
Yeah, so the hyper for acne keloidalis nuca, I'm guessing he's asking, or for I guess for acne or any of them. The hypertrophic keloids can be challenging to manage. Usually our first step is with the Kenalog injections. And often they'll require a higher dose of the Kenalog depending on how big the keloid is. So usually I'll start them at even 10 to 20 milligrams per cc and we'll kind of increase it from there. And I'm pretty persistent with the Kenalog injection, so I see them back about every 6 to 8 weeks to repeat those injections. There are some really thick, larger keloids that you can't even inject. Like once you try to push the Kenalog, it just doesn't even penetrate the lesion at all. Those are the patients that I start discussing surgical excision with. So either if it's a smaller lesion, I'll sometimes do it myself, or if it's larger, I'll refer them on to plastics and they'll excise the lesion. And our goal is to start Kenalog injections about a week after they've had the lesion excised just to prevent another hypertrophic scar or keloid from developing in that region as well. And then radiotherapy is also another option for really large, severe keloids um, that we don't want to excise. And lasers can also be used.
Thank you, Dr. Dashi. I know you talk about metformin being used in HS. There's
Mhm.
a question here from Dr. Ogechi that maybe you should just talk about it briefly again. She's asking that question again.
With HS and metformin.
Yes.
Perfect. Sorry, I'm just peeking at the chat here because I wasn't looking. So with metformin, it can help. Usually helps more in patients who have like associated metabolic syndrome or who have obesity, but sometimes we'll add it on as an adjunct. So I have a few patients who are already on spironolactone, who are intermittent courses of doxycycline, and then they get a little bit of additional benefit with the metformin. And then I usually try and titrate them up to the TID dosing. Sometimes they don't quite tolerate it, but we do find that some patients will find benefit with it. It's usually not a first line or an isolated treatment strategy for HS. Usually it's an adjunct. So we'll add it on to some of our other treatments.
Thank you, Dr. Dashi. There's a comment from Dr. Bisayo and a question also. Thank you for your presentation, Dr. Dashi. Please, can you comment on hyperpigmentation related to doxycycline use?
Oh, yes, that's a good question. So, doxycycline, minocycline, they do carry a risk of causing pigmentary changes, and they can sometimes be permanent, usually a very low risk of causing it. And we kind of categorize them in stages depending on the distribution of them. Oftentimes, they're reversible once we stop them. They tend to have more of a blue-gray hue to them, but that's a side effect that's relatively uncommon, but definitely can be seen with the tetracycline family. Tends to be a bit at a higher risk with minocycline than doxycycline. And then that's one of the reasons at least I tend to use doxycycline a bit more than minocycline itself.
Thank you. For the slides and the recording, I'm going to work with Dr. Odeshi after. Usually by the recommendation of the president and the executive, we put them on the website now. But I will give you more information after the presentation or later in the week. There's a question from Dr. Ugochukwu. Dr. Ugochukwu would like you to throw more light at the recognizing HS at the early stage of presentation. I know you talked about it. Just want you to give a bit of summary and maybe 15 that could easily help us. Yeah, thank you.
Yes, let me just go back to that portion of the presentation here. So it can be quite subtle, and what I usually find is patients will often try, oh, is my screen still sharing? I don't think so. Patients will often try and manage it on their own at early stages. So they'll have a bit of folliculitis, some comedones in those areas, and they won't really want to talk about it. They'll try different cleaning strategies. A lot of times when it shows up early, it's more of these kind of comedonal type lesions. So they'll have sometimes open, sometimes closed comedones, oftentimes a mix of both that will show up. And then they'll have scattered erythematous papules, which you'll think is mostly folliculitis initially, which it is. It's inflammation of that follicular unit. And then gradually they'll progress with kind of these nodulocystic draining nodules. So oftentimes, if they're describing these recurrent episodes, finding out if there's any triggers, if they're finding it's more hormonal related, can give you a clue to HS. And the biggest thing that will really help is examining them. So oftentimes patients are a little bit sensitive in terms of examining those regions, but just clarifying that this is an important stage in identifying or diagnosing the conditions and helping them along the way. And then if you do have a suspicion that this could be HS, a referral to dermatology is definitely warranted. And then starting them on some of those topicals. Usually in the early stages, they can make a huge difference, especially just with the benzocaine, like the benzoyl peroxide clindamycin agents, applying them when they flare. And then even a nodule like this, I'd bring them into the office and do a little bit of a Kenalog injection, and that settles down pretty quickly. So I think the hardest part in early diagnosis is having those conversations because patients often will be hesitant to bring it up just because of the areas involved. But once they do bring it up, just not minimizing their concerns and actually taking a look at those areas. I hope that answers the question a little bit.
Thank you, Dr. Odeshi. Just need to know if you see more slides or this before we continue with questions. I have a lot of questions here.
Oh, no, that's good.
Okay. From Dr. Lotfi, for how long do you advise patients to keep the topical medication on the face before they can wash it off? She's referring to, he or she referring to acne management.
Okay. Are you referring to more so the topical retinoids or any of them?
I think more of, she said referring to acne management with the combined medications.
The combined, okay. So they can actually wash it, they can wash it off, and washing off is more so a tolerance thing. So if they find they're developing too much irritation from the topicals, usually I'll tell them to use it like a mask, leave it on for about 10 to 15 minutes, and then wash it off. Oftentimes, if they're needing to wash it off, that's my sign that this agent may be a bit too irritating. Because ideally, I want them to use something they can leave on. So I might step down on the strength of the topical retinoid that I'm using or eliminate one of the topicals if I'm using a combination agent. For example, some patients might start off on TAC2 pump forte, which has a higher concentration of adapalene. If they're finding they need to wash it off, I might step them down to TAC2 pump or just completely eliminate the benzoyl peroxide component and just put them on adapalene. So usually, ideally, I'd like them to keep it on, keep the topical on or be able to tolerate it on. If they're having to wash it off, usually I tell them I start to step down the strength of the treatment.
Yeah. And that brings my question, Dr. Dashi. With our teenagers struggling with acne, we know the psychosocial stress associated with it. And the African parent, they don't want them to be on contraceptives and also looking at being on chronic antibiotic use.
Mhm.
What would be the best way to manage them with topical treatment? And at what point do you think we should refer?
So can you say the last part of the question again?
At what point should we refer them to you, to the
You asked, okay.
utility?
So usually the oral contraceptives is can be a challenging conversation to have with parents because there is a belief that once we say they should be an oral contraceptive, we're telling them to go out and have sex, and that's not the case. Sometimes it becomes a conversation just to help them understand how much of a social impact this can have on their confidence, their ability to interact with other adolescents or teenagers. And usually it's a gradual almost building a bit of a rapport with the family. And usually the oral contraceptives, if I find there's a little bit of pushback or resistance, will not be the first step. I'll start with the topical agents, see how much improvement we can get with that. Sometimes with antibiotics, we'll even do like a shorter 8-week course, especially if they're tolerating it, and maintain with the topicals. And then spironolactone is another hormonal agent that we can use that's not an oral contraceptive. So that might be worth addressing with the patients. But I think it's appropriate to refer anytime there you feel like the topicals and you've tried a couple topicals aren't quite getting enough improvement, as well as dependent on the severity of the acne. So if you're starting to notice severe nodulocystic scarring acne, I would refer, and then at least we can direct those conversations if the topicals aren't effective.
Thank you, Dr. Dashi. And lastly is about the Accutane.
Mhm.
Um, I know most family physicians might not be comfortable putting patient on Accutane because of monitoring. How do you going to boost our confidence today
Oh,
about medication?
okay. I would love to come back and do another full talk on Accutane prescribing if you guys would like. We use it a lot, so I think our confidence comes from exposure to it, from using it quite often. You're right, there are a number of side effects that you do have to explain and go over with patients and parents uh, before you start the medication. And you need to have a patient that you can trust because the blood work is really important. And some patients will start and you never see them again. So oftentimes I don't even prescribe it beyond a month. I have to see you every month before you get a refill for your medication. It is a pretty safe medication, very limited side effects with it. The most common side effects that do happen are the dryness. So almost all our patients will develop dry skin, dry nose, dry eyes, and that's usually something I warn them about early on. So just having a good moisturizing routine before they start, having an eye drop they can use, and a good lip balm. We will do baseline blood work before I start them. So I usually will order a blood count, so a CBC differential. I'll check their lipid levels, and then I'll check their liver function and their kidney function as well. In rare cases, Accutane is known to cause the triglycerides to go up, which can sometimes cause pancreatitis. So we just monitor for that. We also will monitor the liver function. And then it can sometimes cause a drop in the white blood cell count, so we just watch that as well. Most of these risks are pretty rare and oftentimes reversible with stopping the medication. And you have to remember these patients are getting blood work almost every month. So if anything changes, you catch it pretty quickly. Oftentimes, with the triglycerides levels, even I won't stop them. I might add on a statin while they're on the medication, and then once they taper off, their lipid levels kind of go back to normal. And usually I'll start them on a low dose, and then we'll kind of gradually titrate up depending on their weight. So I'll start anywhere from 20 to 30 milligrams, see them back in a month, and then we'll kind of work our way up. The tricky thing with Accutane is the first month they usually get worse. So they'll usually have a purging phase. So when you see them back the first month, they might look a little bit worse, but with time it does get better. Ideally, we like to say Accutane or Purus is our cure for acne. Once you're on it, you don't need it again. But we're finding a lot of cases they could still have a repeat episode where we need another course. And usually I like to keep them on Accutane till they're clear. So until they're not developing any new nodules, cysts, papules. and then for an additional 2 months after that. And then at that point, I might stop it. So I think Accutane, the retinoids are kind of a whole nother talk on their own, which we definitely can do. Um, but if there's limited confidence, refer on to dermatology.
Thank you, Dr. Odeshi. The next question is from Dr. John. What is your recommendation about the use of glasgosterone cream, Winlevi? I know you mentioned it
Mhm.
in the treatment of acne. The last part of the question is, at what stage of acne is it indicated?
So I would target Winlevi more so towards mild to moderate acne, as an alone treatment. So if you're just using it by itself, you want to use it more so in mild to moderate acne. Uh, Very minimal side effects or risks with it from the patients I've seen back. They often find it's very hydrating, so they don't get that dryness or irritation that you might get with the retinoids. And this one is also a nice one to use in combination with other treatments, especially for that reason that you don't get a lot of irritation with it. So a lot of my even Accutane patients, I'll start them on Winlevi at the same time because it provides another layer of moisturizing, and another way of targeting the acne as well. Uh, the coverage has been a little bit up and down in terms of insurance coverage right now, so I think they're still working on that. But overall, most patients tolerate it well. If you're using it as an alone treatment, I would recommend it for more so mild to moderate acne, and especially hormonal type acne as well.
Thank you. I have another question from Dr. Ose. At what stage is it advisable for GPs to refer patients with HS? Is it when biologics or immunosuppressant treatment is needed?
So that's a good question. It almost depends on where you live. Uh, Ideally, we would see all the patients with HS. I would recommend referring all patients if you have a diagnosis, at least having some level of contact with the dermatologist because the severity can definitely fluctuate, and then we can kind of triage and manage them as needed. Usually, I recommend starting them on some form of TEP topical and maybe trialing an oral antibiotic for a 3-month course for these patients. And usually, if you can put on your note that you've tried something or tried some of these treatments, they are seen a bit faster. So we triage them a bit faster because that shows that they're a little bit higher stage. Anything within a Hurley stage 2 to 3, I would definitely send to dermatology. Early stage 1, where they're still getting a few of these comedones nodules, I think it would warrant trialing some of the topical agents, of course, of the oral antibiotics. But if minimal response, I would refer. In Saskatchewan, I might start the treatments and refer anyways, as the wait times are a little bit unpredictable. So you might be treating while they're just waiting to see dermatology.
Thank you. That was a good response. We should just refer because
Yeah,
of the wait time.
because of the wait times.
Yeah. Dr. Ogechi says, could you please talk a bit about the difference among the different retinoid agents in terms of effectiveness, strength, and risk of causing irritation or purging? Can
That's a
we
good.
give antihistamine before starting to reduce the risk of purging?
Uh, just go back to the retinoid. Uh, are you talking more about the topicals or the orals, or both?
Dr. Ogechi, do you want to ask this question? No? You can unmute yourself.
Topical, sorry. I
The
was asking
topical
about the
agents?
topicals. Thank
Okay.
you.
So the topicals, usually depending on the type you choose, they'll have a percentage. So the tretinoin will come in a 0.01, 0.025, and then increased percentage there. Different as well will come in different percentage. And then you get more irritation once you start to add on the combination type treatments. So usually I find that adapalene or different gel is a nice easy one because it's covered. And usually the titration or the irritation will be limited if you spread out how often they're using it to start. So oftentimes I will have them start by using it every 3 days just to limit that irritation and then gradually increase it over time. And then the other strategies can be to add on that barrier and the moisturizers on top of it to decrease that irritation. Again, sometimes, like I said, the first month they might get a little bit worse, but should gradually get better with time. And I don't think I have a good list of the different percentages, but that's definitely something I can add on to the slide. And maybe when we send it out, they can send it out as well. But the different topical retinoids will have different percentages associated with them. And then you can kind of start on a gentler one. There is I don't know, retin A micro or tretinoin formulation that the whole purpose of this agent is that it's less irritating based on how the micromolecule is formulated, and it's better tolerated. So sometimes I'll use that in patients who have sensitive skin. The problem I find with that is it tends to be expensive and it's often not covered by a lot of insurance agencies. So that also tends to play a role into which of the retinoids I pick. I find Araslo and Differin gel tend to be the one that tend to be covered. The other thing is gels tend to be a bit more drying than creams. So if someone has more dry skin, I might pick a different cream instead of the different gel, because that can be a little bit more irritating as well.
Thank you, Dr. Odeshi.
Sorry, what about the antihistamine use? Sorry.
Oral antihistamines.
Yes.
I don't usually use oral antihistamines for acne management. Uh, doesn't quite fit into the pathophysiology unless they're having other like comorbidities or itch with it. So usually I don't use oral antihistamines for my acne patients.
Thank you. There's a question from Dr. Adetola. Yes, Dr. Adetola is one of our senior colleagues in Saskatchewan, also a family physician and GP dermatologist, asking about where you practice. Yeah, she's with us in Saskatoon at Dr. Walker's Dermatology.
Yes,
Yes.
I'm downtown Walker Dermatology. I also see patients in the hospital, so I do a lot of call. Uh, but yes, I'm in Saskatoon, just moved back about a year ago now.
Yeah, and feel free to refer from Regina. Okay. Dr. Okedo Alex mention any examples of proven hypoallergic or non-perfumed face wash for sensitive face skin.
Yes. So we love the CeraVe Cetaphil brands because they're often bland, hypoallergenic, non-fragrance free. So they actually have a line of moisturizers and soaps and washes. And they also have a few acne targeted treatments as well. I'm just gonna stop sharing and see if I can pull some of them up here. But there is a number of them out there. So between CeraVe, Cetaphil, La Roche-Posay have a nice line as well, and often we'll give patients pamphlets and handouts. And we use these a lot for the eczema type skins as well. Eucerin is another brand. So maybe I'll put a note for myself. That's another thing I can add onto the PowerPoint slides, just a list of kind of hypoallergenic skincare brands.
Thank you. We have like 12 minutes more for question and answer. This is very interactive, and we've had over 130 participants today. This is the largest since my role as the CME director. Thank you, Dr. Odeshi. I think we're still going to come back. We're still going to have more dermatology sessions with you because you're just you're one of the few Black dermatologists we have around. And we're going to make use of that opportunity with you for more educational sessions. I have a question from Dr. Obina. Dr. Obina mentioned that you had a patient that developed rectal bleeding after starting Accutane. Is it a common side effect?
That's not a common side effect. It could be the dryness, if that's a factor, like if there is lots of dryness or friction or irritation to the perianal area, but it's not a common side effect of the Accutane. So I would look into potential other causes of the bleed, and a rectal exam would be warranted as well to see if there's any hemorrhoids.
Thank you, Dr. Deshi. Another question from Dr. Ogechi. How many cycles of Accutane use in total can a patient have how long after starting a cycle can you restart another one? Thanks.
Excellent question. I don't think there's an actual answer or number out there. I think I saw a patient yesterday who has been on Accutane for a year and a half, 2 years straight now, mostly for really, really severe hidradenitis suppurativa. Oftentimes, patients can be on multiple cycles safely as long as we're monitoring their blood work. Most patients will usually need around a 6 month to 8 month course, depending on how low of a dose we have them on, and how fast their acne responds. And then some patients will repeat the courses. And then there's a group of patients where we actually keep them on low dose Accutane for a long period of time. So there's a few patients who just have this persistent acne for a long period of time. So we'll keep them on 10 milligrams per se. And for a long period of time, they'll just be on low dose Accutane. So there's really no hard and fast cutoff to this is how much of a dose you can be on for this specific amount of time. We're pretty comfortable using it long term if we need to and repeating courses if we need to, as long as there's no abnormalities on our laboratory investigations.
Thank you, Dr. Odeshi. Yes, I can see people routing for you here. Dr. Oyedokun, mentioned proudly Saskatoonian. Yes, we're happy to have Dr. Odeshi with us. I was a bit scared. I didn't even know she will be back when she moved to Edmonton, but I'm happy she's back, and we're happy to have you with us.
It's lovely.
Thank you. She was supposed to be with us in Edmonton to present, but for an important reason, you have to shelve the idea till next year. And working with Tosin to proudly bring her to CANPAD conference to have an elaborate dermatology session. I have a comment from Dr. Adedolapo's iPhone. Yes, if there's a way you can advise, because in BC, doctor mentioned that dermatology access is very difficult. Are they online? Because I know I have a Dam Cave virtual dermatology clinic that sometimes my patient access, and they're out of Ontario. What are other virtual clinics that you know about or reliable ways they can use to help their patient?
Yeah, that's a good question. We don't have anything per se in Saskatchewan, and I don't have any experience with any of the virtual clinics. I know there's a derm cafe out there. There's a couple virtual things out there, but I can't really speak to the quality of the medicine per se. So, because I don't have any personal experience with them. I know that it's very challenging, both in Saskatchewan, BC. There's a very limited number of dermatologists. Access is quite limited. Usually I say if you are worried enough about someone, it's worth picking up the phone. So there's a few of us, but at least I work with us. We're pretty collegial. If you're worried about a patient, the severity of their symptoms, might be picking up the phone to one of your colleagues and just having a conversation about them, at least in terms of management, that you can start before they are able to see, or if you think the patient needs to be seen urgently. I'm gonna have to look into that with the cafes, but to be honest, I don't have a lot of experience with their management and how they respond to patient care. So I can't recommend one over the other, if that makes sense.
Thank you. What about virtual consult for out-of-province patient? Let's say our colleagues in BC are trying to call you. Are you able to build that like video consult?
I don't think so. No, I don't think so. I can look into it, but I don't think we take virtual consults from out of province.
Okay, thank you. Help us check that. That might be a way to also help one another. Thank you. Yes, Dr. Adetola, you can now see Dr. Odeshi to Regina. She's with us in Saskatoon for now. Yes, Dr. Esize, there's also urban dam in BC. Thank you. That's a comment.
Thank you for
Yes.
all these questions. I feel like I kind of get a sense of the topics we're interested in. So therapeutics and yes, so this is helpful.
Yes, we'll work towards the therapeutic aspect of this dermatology sessions, and we'll try to bring it back again. Somebody's asking whether you like to move to Ontario. I'm not supposed to say it. My answer is no. From Dr. Lu, in young ladies on Accutane, what will you advise, or what should we ensure for the patient?
Yeah, so I do a lot of counseling for my young females on the fact that this is teratogenic, and I recommend they be on some form of birth control. I'm usually pretty adamant about that. Either they're on some form of oral contraceptive, an IUD, or they're abstinent. And some of my colleagues will actually make them sign a physical contract in terms of saying you cannot get pregnant while on this medication. We do blood tests every month, like pregnancy tests, along with their blood work. And with them, if I don't see your blood work results, I'm not sending your next prescription to the pharmacy. So once you do your blood work and I get the results, I send a prescription for 1 month. Once it expires, if I don't see your next set of blood work, I'm not refilling your prescription. So I'm pretty strict about seeing that blood work and going over that counseling with those patients.
Sorry, I'm muted. Any resources to help GP with prescribing topical compounding products in the community to treat common derm conditions?
That's a good question. There is nothing formally out there. We have a few probably resources or PDFs that we like share amongst each other that we'll use in terms of like topical compounds for lightening agents or moisturizers or anti-itch agents. So that might be another talk that we could do as well as compounding agents that we commonly use in dermatology for different conditions. So I'll add that to my list. But I don't think there's a formal like book or document out there that lists compounding agents, and everyone kind of has their own lists within our community as well.
Thank you, Dr. Odeshi. Um, yes, Dr. Yedokun. I know you know Dr. Yedokun. He said the next major task is to groom more dermatologists. We'll
We
take
will
it.
try.
Thank you. We want more people that look like you to be there, and I'm quite impressed today. You mentioning skin color, and you know one of the advocates for that too from the work you do. Thank you, Tosin. This makes my day. Dr. Ezuku, sorry if I'm not calling the name right. I'm so sorry. I've seen dermatologists asking patients to sign a contract that they are on at least 2 reliable birth control methods and commit to monthly blood work. Thank you. That's what the dermatologist just mentioned. Any sunscreen you recommend?
It always depends on who is asking. So always depends on your skin type, if you have any underlying like photosensitive conditions, and then oily or dry skin. Usually what I tell patients is the one that you will use is the one I recommend. So as long as you're able to apply it every day, usually we recommend repeat application every 2 hours, which can be hard. But for darker skin patients, there's a few ones that don't leave you with a cast. There is one by CeraVe that is hypoallergenic, gentle, and covers at least an SPF of 30. La Roche-Posay carries a few, as well as Vichy carries one that's 60, SPF 60 plus, that's gentle and safe as well. If you look, there's a lot of brands that have sunscreens out there. And oftentimes it's almost a trial and error to find one that works with your skin type. So definitely there's not one brand that fits all, but they're depending on what your concerns or what you're looking for. Some patients are looking for something that doesn't cause a cast. Some patients are looking for something that's a little more for dry skin versus oily skin. The recommendations shift a little bit.
Thank you. exactly 10:30 a.m. here in Saskatoon. That's the end of the presentation today. Let's appreciate Dr. Odeshi. We really appreciate you coming today. And
Thank you so much for having me.
we talk a lot, and I'll keep on working with you to see how we can bring more sessions for our members. Thank you. Thank you for your time today. Thank you, everyone. We'll see you next month. And don't forget, CANPAD conference is coming. Let's be there. Thank you. And have a wonderful weekend.
Thank you, everyone. Bye-bye.
Bye.